Hello, everyone. Welcome to Black Psychiatry. I know we've been doing some things for the kids. We've been gone for a little while, but we are back here for the community. We're happy to have you all and to see you all here. It's me, Dr. Harrison, a doctor named Danny, and I'm here with some wonderful panelists. Frequently, I'm always asked, both at work, in my personal life, just when I'm doing events, what can I do to help someone who's having a mental health crisis? Like, who can I call? Can they all come see me? I can't see everyone in crisis in the Howard ED, even though that's what it seems like sometimes. So how can they get help? What can we do? That is what we're going to be talking about today. We have a great group of panelists, and the topic is, what can I do when I'm in a mental health crisis? And we're going to give you some resources, lots of tips, so how you can help yourself or you can help a loved one, anyone from siblings, co-workers, anyone who needs help. That's what this topic is going to be about today. And I hope that you'll come back to it and have some ideas on just where to go when you're looking for a direction. So for a long time here at Black Psychiatry, you've heard me say for almost over a year that our partner and our sponsor is the Department of Behavioral Health. And I know I've said that, but you haven't seen them here yet. So let me just tell you that we are really happy to have Dr. Richard Bebe, who is the director or the chief for crisis services here in DC for the DC's Department of Behavioral Health. So he is here, and he's going to kick us off. We also have Miss Marie Morales Black. She's the CEO of MBI Health Services. So that is one of the core service agencies here providing care to many of our residents, many of our patients here in DC. So we are very happy to have you here as well. We're going to get into lots of questions for you. You all are going to be, I don't know if you know what you signed up for, but you're going to be answering a lot of questions tonight because I have many. And then we also have Mr. Joseph Williams, who is a social worker extraordinaire at Umbrella Services, another one of the wonderful agencies that provides care to our DC community and patients here. So we are going to let Dr. Bebe start with just setting the tone about what does the Department of Behavioral Health offer, what are the services. We'll get into what is a mental health crisis, who should you call, who should you not call, how we're going to get health first. That's the topic here, and I got that from Dr. Bebe. Like, how do we go back to putting health first instead of some other forces and other agencies, but how do we get into putting health first when we're looking at how do we serve people who are in mental health crisis? So Dr. Bebe, I'm going to start the sharing of your slides and then we'll get back to everybody. So just thank you for joining us.
Thanks so much, Dr. Hairston. And let me just say thanks to you and to Howard University for your partnership with the Department of Behavioral Health over the course of the last couple of years, prompted in large part by COVID and the public health emergency. You've been an important partner for us in trying to meet the expanding needs and the emerging new behavioral health needs for people, including our workforce, the healthcare workforce impacted by the pandemic. I do think that the last couple of years and the public health emergency, there is a silver lining in the sense that I think there is growing awareness of mental health and substance use, jointly referred to as behavioral health needs and issues, growing literacy and awareness, and some reduction in stigma. And I think forums like this are really very critical to seizing the moment and meeting the moment in terms of the opportunity that we have to expand behavioral health services in general. More specifically, as we're talking about tonight, I am now in a newly created position at the Department of Behavioral Health of Chief of Crisis Services, which reflects substantial new investments by the mayor and by the council in behavioral health services and crisis services in particular. And as you alluded to, one of our overarching goals is to improve behavioral health or the quality of our clinical response to people experiencing behavioral health crises, and to move toward a health first and clinician-led crisis response system of care to the greatest extent possible, and so long as we can be safe in doing that. So let me go to the next slide, and actually let's go ahead and go to the next slide. This is the mission of the DBH operated services. I do want to pause for just a second and say that the Department of Behavioral Health is the state behavioral health authority. And part of what that means is the vast majority of routine services and ongoing behavioral health services is provided not directly by the Department of Behavioral Health, but by provider partners that are certified by us, like MBI Health Services. And very happy to be joined by Marie Morellis-Black. And MBI is really our largest provider partner. The Department of Behavioral Health, though, does provide some safety net services, and recently reorganized a number of services under the Crisis Services Division to make sure that we are really providing coordinated care. So the mission of our crisis services, first of all, is to respect that it's the person who's experiencing the crisis who defines what a crisis is, frankly. We want to prevent crises wherever possible, to resolve them quickly and effectively when they occur, and to do everything we can through the resolution and after a crisis episode, however defined, do everything possible to reduce the likelihood that it is a recurring crisis, so that we get smarter about what were the opportunities that were missed to help head off a crisis. What are the access issues? What are the care plan issues that need to be revisited to reduce the likelihood of recurrence? And then ultimately to ensure that district residents have access to high quality, comprehensive, well-coordinated crisis services. Next slide. One of the questions that comes up frequently is what's driving our redesign of crisis and the realignment with the department, which is also happening, quite frankly, all over the country. Our North Star is really, as I said, improving the district's clinical response to individuals experiencing behavioral health crisis. There are a lot of other things going on with police reform. I want to just mention briefly that a year ago this month, we launched a 911 behavioral health pilot in collaboration with the 911 call center, Office of Unified Communications, and MPD. We are working with MPD to increase training. Let me back up for just a second, talking about a clinician-led crisis response rather than an automatic law enforcement response. But our law enforcement partners do have an important role in assuring the safety of the individual in crisis, the surrounding community members, the crisis responders in some instances. But we recognize that many behavioral health crises can be addressed safely by clinicians alone. But our law enforcement partners are out there and encountering people in crisis all the time. And so there's a tremendous new investment and commitment to enhance training for all uniformed officers with MPD by the end of next year, by the end of calendar 2023, with officers at the academy receiving at least 20 hours of mental health first aid training for first responders, officers on the street getting either 20 hours of mental health first aid training or the 40-hour crisis intervention training. And just simply put, crisis intervention officers are a voluntary group of officers that get specialized training in recognizing when somebody's experiencing a behavioral health crisis, training in de-escalation strategies, how to communicate, again, behavioral health literacy, and so forth, so that when police are involved in responding to a behavioral health crisis, they're able to meet it with greater competency and compassion. Another driver is the national rollout of 988, and I'll talk about that a little bit more in a minute. But that's happening in July nationally, and I'll say more about what that is. But all of this, again, there are a lot of activities going on, including a joint effort by MPD and DBH to revisit whether there are alternative co-responses or other specialized alternative responses for people in behavioral health crises, again, ultimately to improve the clinical response to people in crisis. Next slide. Again, this is the goal of the reorganization of crisis services within the department, is really to move beyond having a collection of individual services and assuring that we are working as part of a coordinated system of care. Next slide. So the mantra nationally and the emerging expectation or national standard is that all jurisdictions hopefully will have 24/7 crisis call hubs. They will have mobile crisis responders, and they will have crisis receiving facilities. Another way that the Substance Abuse and Mental Health Services Administration talks about this is someone to talk to, someone to respond, and a place to go. And I'm going to talk just a little bit about what that looks like here, what the standards are and expectations are, and what those things look like here in the district today, and where we're moving. So someone to talk to is the call center, and the expectation is that they operate 24/7, 365, that they provide trained specialists with access to license level clinicians for consultation, that they make provisions to coordinate overflow if call volume exceeds that local center's ability, that there are standardized evidence-based strategies used to assess suicide risk, that they prioritize the least invasive kind of intervention, and that they are able to offer real-time coordination. Someone to respond is a mobile crisis, again with a credentialed staff, responding wherever the person is, able to do warm handoffs if somebody needs ongoing facility-based care, that they're able to support people in getting same-day or next-day appointments and coordinate transportation. All of those are to prevent unnecessary hospitalizations or escalation. And where possible, again, where we can do that safely in the absence of indicators of immediate threat of violence or presence of weapons, that we respond without law enforcement accompaniment, except under special circumstances. And then finally, next slide, a place to go. And here they're talking about crisis receiving and stabilization centers. So let me just go to the next slide and talk again about someone to talk to, the call center, the mobile crisis, and the receiving facilities as they exist today here in the District of Columbia. So the Access Helpline is the district's DBH-operated hotline, and it can be reached by calling 1-888-7WE-HELP or 888-793-4357, 24 hours a day, 7 days a week. Importantly, and you're going to be hearing a lot more about this in the coming weeks and months, Access Helpline is the district's sole affiliate of the National Suicide Prevention Lifeline. We are accredited by the National Suicide Prevention Lifeline, which is a national network of call centers that today can be reached by calling the number on your screen, 1-800-273-8255. The work that we, DBH, here in the district are doing right now, priorities include expanding our 911 behavioral health call diversion initiative. Again, when someone calls 911, the call takers at OUC are being trained to recognize what is a behavioral health crisis and to assess for safety and where possible to divert those calls to us at DBH, at the Access Helpline. We have hundreds and hundreds of calls have been diverted from 911 to DBH over the last year, although the volume isn't what we expect to achieve going forward in terms of impact and the number of calls. We have demonstrated successfully that that can happen. Roughly 2/3 of those calls are resolved by telephone, by the Access Helpline call takers, providing counseling and de-escalation and coaching and skill building and so forth, and linkage to care. About 1/3 of them are resulting in a mobile dispatch of our community response team, which is the district's mobile crisis team. Importantly, as I alluded to earlier, later in July 16th, there's a national soft launch where the 800 number for the National Suicide Prevention Lifeline will be supported by a new 3-digit code, and that is 988. That's based on federal legislation that all phone carriers be able to support 988 as the new 3-digit, easy to remember way to reach the National Suicide Prevention Lifeline. Now that's the sort of the beginning, is July 16th, but over the next year, there will be additional services, including text and chat, that are available through 988. And the vision across the country and here in the district is that the 988 will become the new front door for behavioral health services. We will be implementing new technology in order to facilitate the 911 and 988 initiatives. We're expanding our call takers and expanding our coordination and integration of the call center and the mobile crisis team. Next slide. So mobile crisis is the community response team, which 3 years ago now was reincarnated as the community response team, bringing together 3 legacy programs and adding a 4th function. It operates 24/7 across the district. It provides mobile crisis, homeless outreach services, and pre-arrest diversion services. Next slide. And then there's a place to go, a receiving center. And currently DBH operates the district's only comprehensive psychiatric emergency program, also known as CPEP. Our strategic plan and the Mayor's Commission on Healthcare Transformation recommendation is that DBH work to certify and facilitate funding for additional CPEPs to be operated by community providers. Again, currently the only one in the district is government operated. We have new regulations that allow many of these crisis services to be billed to Medicaid, so that we're not spending exclusively local dollars, budgeted dollars, and are drawing down federal dollars in order to support them. I do want to just make a quick mention that another alternative place to go, or receiving center, that we are working on right now is the establishment of the city's first ever sobering and stabilization center, which will be stood up later this year in a government-controlled building, but operated by a private operator. And we're in the middle of soliciting bids for that right now. It will be 24/7 for people who are acutely intoxicated. It will hopefully allow thousands of ambulance transports that currently take people to emergency departments. It'll be a diversion from emergency rooms, and frankly, it'll be a diversion from arrest in some cases as well, when there's chargeable behavior associated with acute intoxication. So there will be walk-ins, there will be ambulance transports from fire and EMS, and police drop-offs as well. Next. If we can go, I think I had, let me just make sure. No, I thought I had one more slide, but anyway, that is the basic structure of what the department operates. I want to just add to that DBH also via contract with a vendor does also provide mobile crisis services for children and youth, and that's a program known as CHAMPS. So let's open things up. I wanted to just offer that much of a framework for what's happening right now, and then invite my esteemed colleagues to join. And I'm having trouble seeing other folks. I hope you're all hearing and seeing okay.
Yeah, I can see you, and we will add Mr. Williams back to the stream as well. So thank you, Dr. Bebe, for all of that information. It is great to see all of the things that DBH see in that do in that one.
Dr. Hairston, are you?
Can you hear me? Can everyone hear me?
I'm not seeing or hearing anybody else right now, and it may be my connection.
We can hear you. We can see you.
Yes, we can hear you and see you.
Yeah. Okay, well, maybe he will come back. I'm sure he will definitely come back. But I was saying it was great to see all the resources that DBH has, because in one place, because sometimes it's hard to know. I don't know about you all, but well, first of all, I think I call MBI every day. And I think I also call the Access Helpline every day, and probably talk to CPEP at least a couple times a week. So before we go into too many questions about DBH services, I really want to talk to you two, because you are here like in the community, really working. I'm working also, but I'm working in the emergency room, but you are like right there in the community with our people, with our patients, with our loved ones, with all of us. So what is a mental health crisis? Like, what is something that people can call for if something is going on? Is it how big or how little? Is it if I'm feeling down? Is it if someone's running around with a knife, or anything in between? Either of you, is this, when is it time? What is a crisis? What do we do? When is it time for a family member or for myself to call someone to help me?
I can start. I think whenever people are in psychological distress, and as Dr. Bebe mentioned earlier, is that the individual determines what the psychiatric, psychological crisis is. Because if the person feels that they are in crisis, well, they are in crisis and they should get some help. And crisis can be led by a psychotic disorder if the person has mental illness, or if it's a normal population, it could be dealt by a psychological distress, which means the person is having heightened anxiety. They are not able to control their emotions. They may be experiencing some behavior outrage, and they are feeling out of control of their own behavior and emotions, or the person they're interacting with is feeling like they are in crisis. And so if any of those things are happening, then the person is absolutely having either a psychotic episode or psychological distress, and they should ask for help.
great. Thank you for that. Anything else, Mr. Williams? Oh no, we can't hear you. Oh, I gotta unmute you. There we go.
Okay. There we go. Okay. Similar to what she just said, thoughts of harm to self, harm to others, decompensation, anxious distress, severe depression where you don't feel that you are worthy of life, or thoughts of harming others, which will ultimately put people around you in an unsafe situation, are most of the crises that I've actually, had to respond to.
Good point. Thank you for that. That we think about as well. When people are so down, a lot of times people think that you're calling the police when someone's like, or calling for emergency help when someone is like behaving erratically or they seem like they're psychotic or manic, but also when someone is extremely down. I think also it's important when someone is so disorganized that they won't be able to function out in the streets. Like if they don't know who they are, they don't know where they are, they're not eating, they're not sleeping, not maintaining those things. Those are also a time that you should make sure that you call for some help. So I'm saying make sure to call for some help. Who are we calling for help? Who should we be calling? Are we calling 911? Are we calling DBH? Are we calling you? Are we calling you, Mr. Williams? Are we calling you, Ms.
Well, if I was to answer that question, usually for myself as a therapist with Umbrella, I tend to initially start with a crisis plan when we start off. And I know MBI is well aware of that. Usually when we meet our clients at the intake level or the diagnostic assessment level, we ultimately try to get a baseline as to what is a crisis to the client and what are some of those behavioral indicators, which may not always be the case, what indicates that you are currently in crisis, right? And then what we tend to do, we have a tickler, and then we start to develop those emergency fail-safes, it starts with natural supports, but then it also includes those, the CPEPs, the CHAMPs, also, end all be all 911. Who are those people that you love, trust, that you care about, that can ultimately bring you to a place of solace, even if it's temporarily, that you trust to share that you may be in some form of crisis. And then ultimately, if we know that this does not work and there is no other means to get you to a space of stability, these are the numbers that you contact. You can contact them anytime, but ultimately, we want to be able to keep you safe and keep the people around you safe because you matter. And so we always kind of start at that crisis level. And those crisis plans are very important. And I tell people we should update them all the time. It's a working document, just like a treatment plan. So our clients, or particularly the clients that I service as a therapist, they are well aware of who, whom, and where and what to contact when there is a crisis situation that they have no management skills in.
Thank you for that. That was a very good explanation because, again, it's personal. Like a crisis for me is not the same as a crisis for you. So it's important that we all understand that it's tailored. I like what you're doing over there, Ms. Williams. It's tailored to everyone. Like one person's feelings are not the same as another person's feelings. One person's crisis. I say this at work all the time. Your crisis is not necessarily my crisis. So we got.
Yeah. So let's go there. Let's go there. If I was to just kind of rip something from reality, imagine this: a client recently separated, and then there was a divorce paperwork sent to the house, and then you find out all of these other things, and then miraculously you were not reinstated at your job, renewed your contract. So everything around this person seems to be falling apart. Yeah, they're not, they didn't witness a murder or anything like that, but imagine your life for which you've designed is starting to fall apart and you don't know what's next. So that means financially you feel compromised. Your romantic relationship or marriage is now compromised, but then it becomes a big blow to self. That is a crisis for a person. And then they start to question, what is there to live for, or what's next for me when all I know is this? And so we oftentimes have to be able to tailor what that looks like, because in a circumstance like that, that client actually had to have CPEP get involved, you see? And this is a higher functioning consumer, but because of everything around her seems to be going haywire, she had to have that intervention, which she was very thankful for at the time.
Yes, I totally agree, Mr. Williams. I think that they are what I call situational crisis, where a lot of things are happening, and as a result it becomes it crescendos into all of these things that you just described, and the person are not able to cope with all that has come at them with the total stress. I was talking to a colleague, a friend, who says, when do I know that this problem is in need of intervention?
Mm.
Okay, and that's what was she asked, and my response was, is it impacting day-to-day life functioning? And so if anything that you are experiencing is beginning to impact your day-to-day life functioning and is having impact on your functional self or the function of the family because of what's going on, it may be time to ask for support and for help. Um,
Absolutely.
and I said that with with children, is school creating chaos? Are you getting a lot of calls from school? Are the behaviors such that they are not able to learn? Those are the times you need to go and get an assessment and find out what's going on. Same thing with the adult. If you are moody and people are saying you're hard to get to be around, if you're not able to get up to go to work in the morning, if it's beginning to impact your day-to-day functioning, then you need to get help. And so that's one way to know that you are in a personal or family crisis. The other piece is that, as Mr. Williams mentioned, is that there is something happening that is creating some agitation and behavioral dysfunction right now, either to yourself or to others. And that is an immediate crisis. And then that's when you need to have somebody call for an intervention. And for after hours, you want to call the mobile crisis if you are in the community. You want to call Access Helpline. During the day, you can call one of us. You can call
Absolutely.
NBI, you can call Umbrella. Okay, you can call one of the core service agencies that are available and make an appointment to come and see a psychiatrist, see a mental health professional to get some support for the long haul. So there's two ways to manage this. Is one, you've identified there's some functional issues. You then say, I'm going to get help. And then there's the immediate crisis where you need to do something right now. And I think that's what Dr. Bebop was talking about, the 988.
Yes. Which
Yes,
is going to be amazing.
we're gonna
Which is
get
going to
into
be
what
truly amazing.
988 is.
And
Yes.
we'll be able to give you our numbers too.
Well,
So
I
that
have your number, but yes, please put the number in the chat so we can share that, because I call you every day. MBI, I call you Umbrella, and I call DBH over at Howard. We use all the resources so we can help everyone in the community. Also, let me add something that is important, is that when you do come to the ED, I appreciate MBI, I appreciate Umbrella, and the other core service agencies, because they will come and pick up their patients, like wrap around. Like they'll say, okay, Dr. Harrison, I see you don't need to admit them. I know they need some help. We're going to come pick them up and take them back to our building so that we can help them and, give them the services that you aren't able to provide, but I can do that very safe and healthy handoff. So we're talking about all these resources. I need to ask you all, is a mental health crisis, is that a police issue, or is it a health issue? Is it a legal issue? Is it an EMS, an ambulance issue? Like, who is supposed to be helping? Now, there might be a clue because we talked about this panel is called Health First, but I just want to know, some people might want to know what kind of issue is a mental health crisis?
Based on my experience, it can be all of those things. It can truly be all of those things. Consequently, we want to be able to put the client in a safe space, but ultimately it can be a health crisis. It can be a 911 call because of the behaviors that are exhibiting based on the mental health crisis. So the goal is that we are all properly trained to manage through those things, because we've seen things both nationally, locally, where it involved the police, it involved a life. It involved, other people based on a mental health circumstance the person was dealing with. So it can be all of those things at any given time.
If I can
I
jump,
hope that answered the question.
if I can jump in, and I apologize for the interruption, I want to take a step back for a second and thank Mr. Williams for emphasizing the use of the crisis plan. The real name of the game with crisis is crisis prevention, and an ongoing collaboration between the helpers and the individual in understanding what a crisis looks like for them. What are the first things that you notice if you're starting not to do well? What am I going to notice if you're starting to not do well? And updating that crisis plan actually helps to increase a shared understanding between the helpers and the individual, as well as that, as I was saying before, helping to effectively resolve things. We don't want to do things that are going to make things worse. So having those conversations with people repeatedly about what helps and what doesn't, who's helpful to you, is a hand on the shoulder helpful, or is that agitating for you? So I just really want to reinforce that the goal is to prevent crisis and to build new lessons into the care plan going forward as much as possible. To Dr. Hairston's question, it seems deceptively simple, but it's actually very complicated. It is a health crisis, no question about that. One of the issues, one of the challenges, the community response team, the DBH operated mobile crisis team, and the CHAMPS program have a standard arrival standard of 30 to 60 minutes. So one of the questions is, can the situation be managed safely until the clinician only team arrives? We don't ride with lights and sirens. So now the other thing that I want to say, however, is that our real goal is for the general public not to have to know which place to go. We want there to be a no wrong door. So over time, calling 988 or calling Access Helpline or 911 or the CRT directly, if we're doing our jobs well and really creating a seamless, very integrated crisis continuum, the professionals should be able to sort that out pretty quickly. It may be that first responders need to be there just to render the situation safe until clinicians come. And I said this really just in passing, but the Chief Conti and our director, Dr. Barbara Bazran, director of the Department of Behavioral Health, have tasked their teams with revisiting. In fact, we're traveling together in a couple of weeks to look at co-responder approaches. We have not made decisions about if and when we're going to do that, but we're wanting to create a more and more layered approach so that we have a diverse set of alternative responses that really optimize the clinical response, minimize unnecessary law enforcement involvement, minimize unnecessary admissions and so forth. Involuntary admissions can be quite traumatic for people, and we don't want to do anything that leaves people less likely to reach out for help the next time.
I definitely agree on that. I think that that leads us to my next question, because we do know that it can be an all-encompassing issue, right? It can become an issue for the legal system. It can become an issue with law enforcement. It can become an issue, a health issue, I think, but the focus should be back on health. But that's not usually who responds. If it is a solo, only a police officer or law enforcement responding, what can be missed? What do you think, what can be missed if someone is calling the police for their loved one and it's solely, or calling EMS or calling 911 or calling soon 988, and it's solely the police responding? What what situations can happen or what can be missed in these situations? Anyone?
Let me, I'm glad to jump in quickly, but I'd be very interested in hearing from our colleagues. But I think, as I said earlier, as much as MPD and DBH are committed to having a very more literate behavioral health literacy and increasing skill level among police, they're not trained clinicians. Secondly, people have had, it can be triggering for people just to, no matter, we may have the very best crisis intervention officer on the force showing up in a uniform with all the gear, and it looks quite militarized these days, can be triggering. And people have had bad experiences. So it can be escalating regardless of the compassion, knowledge level and skill level of the officer. So that's why we want to move as much as possible, as much as we can safely move to clinician only or clinician led kinds of responses.
I totally agree. I think as you were talking, Dr. Bebout, I was thinking of the trauma continuum, right? The different, because most of folks that are experiencing distress have some history of trauma. And so when the police, and sometimes that trauma has to do with police involvement. And so when the police shows up sometimes alone, what happens is it creates a trauma response, and typically it's fight, flight, or freeze. And so if it's a freeze response, it's palatable for the police sometimes. And if it's a flight response or a fight response, then it can create some challenges in the system because of how police are trained to respond to flight or fright. And so as a result of that, it puts that person who's experiencing a mental health distress in harm's way. And so as a result, it can create an unintended response for both the police and for the person experiencing distress. And so I think for that reason, if you're dealing with a mental health distress and it does not include a weapon, or if the assessment can be made that it's not an imminent danger, that a mental health person should be responding with the police or a mental health team response instead.
Perfect answers. You agree? Were you going to say same, Mr. Williams? Yeah.
I wanted to add, and I totally agree with that. Just with the 20-something years of experience that I have, it just puts me in the mind state. I'm just going to be brief with this quick story. I recall when I was working with Child and Family Services, a small child was brought back to the office, to the main building with all of her stuff. And I believe she was placed in a foster home. The foster mother was looking for respite care for the kid, but the social worker was unable to find it. But the foster parent was taking her family on a family trip, which included kids, but because she wasn't quote unquote family, she was unable to go. So as it stood, she brought the little girl to the agency to give her back to care after she was placed in this woman's home for almost 5 years. And the girl had a episode in the lobby, which included the special police officers and everything. And I just remember I was coming into the job and she was throwing things around all of her stuff. And I just remember seeing this little girl get lifted into the air, restrained by the police. And I just stood there and didn't know what to do. You know, as a worker, I'm in my office, you know, wasn't a situation that necessarily involved me. But I just remember hearing her say, "You guys don't know what I'm going through." And to see this girl taken away in handcuffs and placed in juvenile because of her reaction to being rejected, which re-traumatized her. I just recall that, and from that point forward, on an individual level, as a social worker therapist, I said that I'm always going to hear what's being said beyond what's being done. If there's a safe situation that does not involve a weapon, let me hear what the issue is as opposed to reacting to the behavior. If the situation is not where my safety is compromised or the safety of the client, sometimes we have to hear. And I believe with this young girl's capacity, she couldn't say, I'm hurt, I'm disappointed. The only thing to do is just to destroy the lobby. That's the easiest thing to do. Who's willing to hear me? So I think those things are very important just on an individual level as clinicians, as service providers. We have to hear, because sometimes I tell workers this all the time. A client will show you something's wrong before they will tell you something's wrong. And so we have to be able to look at those indicators, and they are the own experts. They are their own experts. So we have to be able to see that. And sometimes, like you say, there might be an adverse reaction based on, the police defending and protecting, as opposed to understanding what's going on. And with all due respect to the police and our police departments throughout our city, we have to be able to put our clients also in the same situation, be able to hear what they're saying by watching their actions as well. I hope that made sense.
That made a lot of sense. And I can say that I've seen similar situations, and that for those amazing, supportive mental health providers, social workers, psychiatrists who work with the child patient population. I work in the emergency setting, so I do see children coming in that way. But I think that what I've learned from them is that you don't ask what is wrong with this kid, you ask what happened to that kid. And unless we are able to embrace that, then we can't help them. So, and we're talking about helping, and thank you for sharing that, Mr. Williams, because I think people need to understand, like, when you see a quote unquote bad kid acting out, like, what's going on, but know that these quote unquote bad kids, they, without treatment and care and coping mechanisms, become adults as well, who also have this poor frustration tolerance. They're not able to do this. They lack control. So then when they do come into the emergency room or to CPAP and are destroying things like that, like, what's going on? So I love that you shared that they're going to show you that something's wrong before they may even tell you specifically. That's something that we see in our Black and marginalized communities. So we have to make that point. So my next question.
No, I was just going to say, what you are referring to is a trauma-informed care, right? And I think that, when you say, don't ask what's wrong with me, we'll ask what happened. And I just came from a trauma-informed training for our staff a little bit ago. And one of the things we also reminded them is that you have to connect before you correct. And so often when people are agitated and are escalated, we want to tell them what they should do versus connecting them and listening and asking them what happened. And I think that when we do that, then that often will de-escalate the situation instead of telling them what they should be stopping to do right now in the moment when they're agitated.
Yes, thank you for that. Now we gotta connect before we correct. We gotta ask all these questions. Okay, y'all are giving me great. So Dr. Bebe,
I'm taking notes right now.
Yes, Dr. Bebe, even before we got on here, gave me the help first. Now I got connect before you correct. Yes, and Dr. Williams I gave you a doctor already, but yes, Mr. Williams gave us, they will show you before they tell you. So thank you all for those. I hope that the audience and our viewers are taking these bits with us. My next question for you all is, what are the goals, or what does a successful crisis response team look like? Like, what do they do? How do they help? And I also, I listened to a podcast actually that had someone from CPEP's or from DBH's crisis response team. But actually he said the name was actually now the community response team, because that was important. That language mattered. So what does a community response team and a community response approach look like? Or we'll also say crisis response team, because that's the term that people are also familiar with. But what does that look like? What are they doing? What are the goals? Like, what if I'm calling for my family member what are you going to do? I don't want my family member to be locked up and going to jail. I need help for them. So what are the goals? What does a successful team look like?
So I'll address for the community response team. I think just to be concrete, we typically send people in pairs, and the pair ideally includes somebody that is sometimes a licensed level clinician, but a trained behavioral health specialist. Very often, and as much as possible, we are pairing them with certified peers who are individuals that are themselves in recovery from mental health or substance use disorders, have been trained and are uniquely positioned to use their experience to connect rather than correct, if you will. And so the first thing we want to do is to de-escalate things. Our teams are trained to assess. They do have the ability to initiate an involuntary hold, but that's a sort of a last resort. To the extent that we can engage, and again, we go to them to the extent that we can engage with family members who are concerned and who are incredible historians and who know what buttons get pushed or what's helpful and what's not helpful. So if we can leverage all of those supports to prevent somebody from being unnecessarily hospitalized, or certainly from escalating so that there is chargeable conduct. I used to work in behavioral health in the DC jail. And while we worked to create really very good clinical programs in the jail, that's not where people with serious mental illness or behavioral health challenges are really going to get better. So we want to do everything we can to prevent institutional people being hospitalized or jailed. So I'd like to hear from others as well, because again, while we have crisis services as a backstop, the other providers, and especially providers that provide the highest level of care in the community, assertive community treatment, crisis responding is an essential part of what they do as well. And crisis response by the sort of the home team, if you will, of the behavioral health home, is much more likely to lead to a successful resolution than when strangers are intervening.
Absolutely. I think and again, it depends on what stage of engagement the community is in, right? Because if they are not engaged with any provider and they're in crisis, the community response is their first place to get services because they're not connected to an agency. However, if they are connected to MBI, and particularly are serious and persistently mentally ill patients, we do have an integrated team that includes nurses and a psychiatrist and recovery support specialists and clinicians to really work as a team. And that team is included with a group of folks who on a daily basis review cases, so the entire team knows who the folks are, so that at any point that person is in crisis, a member of that team can respond and knows that person to really help to manage the crisis prevention plan or the crisis intervention plan that has been created, that was mentioned earlier, and to to help them regulate. One of the things that we in our trauma-informed system of care at MBI, we talk about the 3 R's, right? We talk about regulate, relate, and reason. And so when folks are in crisis, we help them to, as part of that process, to regulate and then to be relatable and to re-engage them back in services and to de-escalate them. So if they are part of an agency, I'm sure Umbrella has the same thing. That's what we do. We do provide interventions for those high ends 24/7, 7 days a week. We have on-call people to really meet that need, and then to really exercise the intervention plan if they end up in crisis. And then following that, one of the things that we would do then is to look at that crisis prevention plan and make sure what happened. Okay, so we'll do a post debrief so that we can find out what didn't work, what happened. We look at the antecedents of the behavior, so that we can figure out, is it an undue stress that occurred? Is it the plan that we had in place is not working? Is it because they didn't take their meds, if they are on medication, to help manage that? So then we have to dissect and look at what happened so that we can then create a plan that really then can ensure that we reduce the likelihood of hospitalization, rehospitalization, or crisis in the community.
Absolutely. And the teaming piece is very important when it comes down to the therapists, the community support workers, the community behavioral interventionists. On a daily basis, we oftentimes find ourselves, exchanging information about shared clients. We exchange information about other resources or natural resources for the consumer. We always have a release of information ready, actively available, and ready for a client who may have other resources that we can communicate with them most appropriately. And so I think the teaming and the ongoing supervision of just openly talking about cases, because oftentimes we can start a Monday workday and we can find out by the end of the day, this particular client needs to be monitored a bit. There's a couple of things going on and we're expecting, or we can expect something to probably unravel. So let's jump on top of that now. And jumping on top of it may look like, extending sessions, increasing for the week, ensuring that we're putting safety plans in place for the client when it comes down to things that may happen. You have to understand right now, just in the space in the midst of global crisis, as well as, as of tomorrow, we have people who are facing evictions, not literal evictions, but, people who are behind on their rent, where they may in fact be traumatized by getting a writ or some sorts, where their stability for a number of years may be compromised based on the lack of employment. Those things are very important. So, right now we've had these conversations weeks ago to talk about what are some of the strategies that we can put in place when it comes down to assisting them with coping. Yeah, we can't control housing dynamics and monies and all of those things, but we can also kind of assist the consumer in the space of those shifts that may take place, which are beyond their control, where we just don't know. So it's always good to kind of be abreast as to what the client in circumstance or consumer in situation, and always know that what do we need to put in place. And then we have to always remind ourselves we're dealing with live human beings, just like you, just like me, and that things can shift, things can change at any given moment. And so we always have to be ready and actively available, with boundaries, to find out what can we do to better assist this client, or what can we put in place. Yeah.
So thank you for all of that. I think that those are wonderful points from all of you, and I appreciate all those answers, because each of you, or each of the services that you work with, really, I see how you work, like as a person who works in the emergency room, in the emergency department, like looking at how we reach out to you, you come, you get them, or we send them and send our patients to you directly, like with a cab voucher, the bus token, somehow to get you to the services that you need. And I think that people who are not involved actively in providing mental health care also don't understand the impact of unstable housing. Like housing instability, housing insecurity results in a lot of emergency room visits. It results in a lot of distress, depression, anxiety. And it is something that, if we could, I say, like, if we had keys to apartments on our inpatient unit, we would give them, because it would be a great resource. But I think people don't understand how much that leads to both incarceration, institutionalization, and mental health crises also. Dr. Bebop, this question might be for you, because I know that you know the data. Has there been a change in the amount of arrests, amount of people going to trials, um, incarceration for mental health issues because of community response or crisis response teams? I know that the catchphrase is that the prison system is the biggest provider of mental health services in this country, which is kind of, they don't really get that many mental health services, so that's an unfortunate stat. But do you know, has there been a change? Like, is there an impact on these community response teams, on core service agencies like MBI and Umbrella working? Is there a positive impact or negative, any type of impact on the number of incarcerations or arrests that we see?
So there's definitely a positive impact. I mean, a reduction in incarceration and arrest. I think, the issue about the interface between mental illness or behavioral health challenges and criminal justice is complicated. There is criminal conduct really ultimately the result? What's the underlying driver? What's the underlying cause? And if it's really driven directly by symptoms, clearly treatment is preferable. And so there's the mental health diversion court here in the district. And I think your question, and I don't have data at my fingertips, and just to perhaps to state the obvious, the prosecution and detention of people for relatively minor crimes has been extremely significantly lower during the pandemic. So we do hear about people cycling and being rearrested frequently and not being held. I think, but I want to go back to what you were saying about housing instability. And the other thing is that when criminal conduct is really situational, it's driven by food insecurity or housing insecurity, or people are engaging in survival crime, stealing in order to eat, or sex trade, again, in order to survive. And we certainly want to get away from prosecuting for any of those kinds of things, and doing a better job of identifying what the social determinants are that are driving crisis or emergency room presentation, or people cycling. And again, as I said at the outset, the community response team brought together 3 legacy programs: the pre-arrest diversion pilot, homeless outreach, and mobile crisis. And as we are building, we've been building our team up in part because of the 911 and 988 and anticipated increased crisis calls. But we really want to be sure that we're doing a good job of diverting people before a chargeable offense occurs, or if a relatively minor sort of nuisance crime occurs, nonviolent crime occurs, and it's really a behavioral health need. We want to get those people securely connected to the right care.
Thank you for that. I also want to say that I do think that treatment works. I wouldn't still be doing this work if I didn't believe that. I think that when mental health is managed, and when medication is warranted, it works. One of the things that we do at MBI, even at orientation, is to help people understand that mental illness is also genetic. It's physiological. And there are times that, just like when people have blood pressure or cholesterol, and food modification doesn't work, or diabetes, mental health is very similar in a lot of ways. They are brain, and physiological things that impacts things that sometimes it requires medication to mitigate it. Many folks don't take their medication, then it doesn't work. And so I think we need to teach the community about the fact that mental health is similar to physical, even though it's not as um, um, diagnosable through a test right now. But I know the research is happening through the neuroscience to really help to develop that. But I want people to understand that if you get the treatment you need, and if it is determined by a physician that medication is necessary for treatment, you need to support it and you need to take your medication, because that's how you stay well. And there are many of folks who does that, and they have become productive, normal functioning members of our society. We see it at MBI. They go to work, they get married, they get their life back. And so I think I want to remind people that there is such stigma, particularly in our community, around mental health, that we need to understand that it is part of the continuum of illness. And there are toxic stress that lead to mental illness, but it's also physiological. And no matter what you do, you can have it because your mama had it and your papa had it, and the gene has been passed on to you, and then you're going to have it too. And so I think that folks have to understand that it's both. It's environmental, situational, but it's also physiological. And so therefore you have to get help. You got to get support, because when you do, it works. In the homeless prevention community, we say housing is health, because you can begin to start working on people's health outcomes until you get them stable housed. And that's why we see the physiological as well as the mental health outcomes for people who are homeless 25 years less than the normal population. And so it is an issue. And once you get them stable housed, you help them to manage their mental health, they get better. The great thing about the brain is that it heals. It can heal.
Thank you for that, Ms. Morales Black. And I will urge you, and everyone watching, everyone who always watches the channel knows that I say that mental health is health. Like, there's no separation. Mental health is health. There is no health without mental health. So you can't have one without the other. We've been trained in so long as a medical doctor to separate them, but actually you do better when you bring them together. And I've often say that it's sometimes easier for me to get my patients to take their medications than it is for primary care to work with their patients who have diabetes and hypertension, because we got to change the diet, they got to take their medication, they got to walk and exercise. It's a whole plan. So it's the same thing with mental health. We have a whole plan. It's not just one thing. And I'm someone who teaches about systems and structures and systemic and structural racism. So we have to understand like that all policy is health policy, like all policies and all issues affect your health, whether it's education, whether it's housing, whether it's taxes and what funds what, and where there's a food desert and where there isn't one. That all has to do with policies that have been put in place intentionally to reject and neglect certain communities. And I'm talking about Black communities and other marginalized Black and Brown communities. But before I go off on that tangent, I would just want to, there's questions in the chat, but I do want to make sure that I ask Dr. Bebe what is 988, because someone just asked me about that. And I was like, I don't really know what 988 is doing. And I want to also know from our other panelists if they have any concerns about 988, or are they looking forward to 988? Are you worried about 988? Because some people are saying that 988 is just the emergency suicide line. So what is it, Dr. Bebe? And then my other panelists, tell me what you think about it.
So 988 is the new 3-digit call code for the National Suicide Prevention Lifeline, which is an 800 number now. But And what's happening, the legal requirement for July 16th this year is that all of the telecommunications carriers support 988, feeding into that network as I described earlier. However, the long-term goal is for that to become like 911, that people know for behavioral health, that's what you call. So that 988 is gives you access to certainly suicide prevention help, but also connections to care, both urgent and emergency care for behavioral health. We have we will be messaging. You'll be hearing more stuff in the press, but the July 16th of this year is really that floor in terms of switching over. The 800 number is not going away, but 988 will get you connected to National Suicide Prevention Lifeline trained, accredited call centers. But then it's going to go from there. And I think, 3 years from now, we probably won't be publicizing the Access Helpline as a separate number. We'll be publicizing 988. I think we will still be telling people that they can get connected to behavioral health care through 911, but that there are a lot of people, as you've alluded to, family members, concerned neighbors, and so forth, that don't want to call 911 for somebody that's in crisis, but they don't know alternatives. So we want to make it easy for people to get the right care at the right time.
Thank you for that, Mr.
I'm
Williams.
excited about 988. I am. I'm excited about 988. However, I'm cautiously excited because I think that it's all on the rollout and the implementation. I think of 988 like the DC 311, right? You know that if you have a non-emergency or you have an annoyance, you can call 311 and they'll take a ticket and they'll try to resolve it, right? And I see 988 as the similar 911 for behavioral health interventions. And so the goal is that from there, people will know how to access support long-term, and they will also get connected to agencies like ours on the panel, and they can actually get treatment and get better. I think that if it does that and it decriminalizes or it stops the police to respond to mental health escalation, that often goes bad, right? Not often. That goes bad enough that it's an exciting thing for the country. I think 988 is one of those things that comes out of police reform and to really stop the police to focus on police issues versus behavioral health issues. And I think that if rolled out, it will be a really good thing for our field so that mental health can be supported through the folks that are expert in that issue.
Absolutely. I agree. I think it's all about the rollout. I'm really excited about it. I'm glad that we have like a small number that we can just kind of give to our clients as another form of presentation. The bigger part that I'd like to stress that I'm really big on when it comes down to just providing information to our clients. There's an old episode, I won't name the show because the name associated with the show is not too popular anymore, but there was an episode of a show where this daughter brought a man home and, the guy was a good guy, but she just said, I'm getting married tomorrow, yada, yada, yada. And the father said, we don't like you because it was the way that she brought you in here. You could actually be a great person. So I think that when we're rolling things out, we always have to be able to present them in a better way, as opposed to on the top of a trash can. Here's a number, this is what you call, let's keep it moving. Let's talk about when to call these numbers. Let's talk about what this looks like. Let's talk about the information and the presentation of visuals associated with suicide prevention and everything else. So I think when we, just on a smaller scale outside of the national number, we have to be able to present these dynamics to our consumers where they feel like they can actually touch it and grasp it for themselves. And that's the most important thing. Just some of the people that I work with, I'm always telling them, stop giving our consumers information on a trash can, put it in the best presentation possible. Let's make a phone call. Let's talk to somebody. Let's talk to an expert. Let's see how we can actually really work this program as opposed to me shuffling you through and giving you a number. So I'm really excited about it. I'm really hopeful that this will be another form to, put preventive measures in place for a lot of people who wouldn't have otherwise made contact. So I'm excited. I just want the rollout to be right. So I'm looking forward to it. In any way that I can support, I'm definitely here. So, Umbrella's definitely here.
I like that. We already know that language matters, but we also need to know that presentation matters, and like how it's rolled out, how it's packaged. Is it just, oh, here goes your number, get out, we'll see you later, or here's a number, this is what they do, let me call with you, let me sit here. Like, those are all things that are important. So I'm glad that you all brought that up, and that people who are active in this rollout for July, because tomorrow is July 1st. It's also Bebe Campbell's Mental Health Equity, formerly known as Minority Mental Health Month, but we're not trying to embrace the minority term anymore. We are the global majority. So we are saying the Bebe Campbell Mental Health Equity Month is coming. So I hope that people really talk to their family members, talk to their loved ones, talk to their friends. I always tell my panelists, can they protect 90 minutes? But I try to not take all your time for the evening. But I do want to say, again, thank you to all our panelists. Thank you to our sponsor that's been our sponsor for a while, but I'm happy that now our sponsor is actually really live and here in the building. So Howard and Black Psychiatry, the DC Department of Behavioral Health, have been working together to bring these services, to bring this YouTube channel to you for, I think I've been working with y'all for almost a year or over a year. So thank you for joining us. And I want to make sure that I say again that July 23rd here in DC at Howard University Hospital. If you don't know where it is, it's Georgia Ave. Okay, Georgia Ave, the Howard Shaw Metro. You can't miss us. We are having a mental health fair, and I hope that DBH is going to be there. I hope that Umbrella is going to be there. I hope that MBI is going to be there. I'm going to be looking for all of you to show up on that Saturday. We're doing everything because, I said that all health is health. So we're going to do meditation. We're going to be doing workout, nutrition, food, books for kids, backpacks, everything. So wonderful. I need you all to be in the building packaging up that information. Remember, Mr. Williams said we want to package up the information. So I need y'all there delivering the package for us to the community. Howard, DBH, the American Psychiatric Association, we will be there live in the community. I know it's going to be hot. We're going to have water. We're going to have fans. It's going to be okay. Because I don't want y'all to go in the ED for another reason, because it's hot out there. But we thank you so much for that. I do want to just get to one question that I did see over here was asking about schools. So does anyone know, like, do school social workers, psychologists, teachers, do they have any resources specifically for them here in DC who can help them? I know that Howard, we have a school-based program.
We do too.
School, okay, MBI has one.
Yes.
And as well as Umbrella, yes, we have people that are in and out of the schools. And then the schools have also, if I'm not mistaken, I don't want to speak wrong, but I do believe that the schools do have some liaisons from Department of Behavioral Health that are actually placed in some of the schools, in some of the programs, yes, in most of the programs, if I'm not mistaken. So
there, yes, thanks. There are DBH clinicians that are in many schools, but broadly over the last several years, there's been funding progressively added so that there can be a mental health, behavioral health clinician in every school, and in every public school and every public charter school in the district. I would also say that the CHAMPS program, the Children's Child and Adolescent Mobile Psychiatric Services, recently got expansion funding specifically to serve schools, and schools are really the largest source of referrals to CHAMPS. So the mayor and the council have worked with DBH and OSSI, the Office of the State Superintendent of Education, and so forth, to really expand the availability of behavioral health supports in schools.
Yeah. And MBI is part of a cohort of community-based agencies that actually have clinicians in school. We are currently in 25 schools, and then there are other agencies like us that are also in other schools. So we are providing the support so that we can bridge it to the community.
Absolutely.
And we do have full-time clinicians in the schools as well.
Yeah, more schools are supported by CBO clinicians that are being funded through DBH, along with supervisory supports. But yes, so there's both the DBH employees, but a greater number. The expansion has really built on our community-based partners, such as our esteemed colleagues here tonight.
Okay, thank you for that. So CHAMPS is a resource for DC, for teachers, for students, for families, for parents. Mr. Williams, you have something else for us?
Yes, I would be remiss if I did not put this on the table, and I've been fighting this the whole time that we've been talking. Just with some of my elderly clients, I do know that there has been times where there has been crises, and there has been some referrals, some suggestions of entities that they can be referred to if they need a mental health break or some sorts. And a lot of my elderly women, African American clients, have had really terrible experiences in mental health institutions locally as it relates to being bullied, being manipulated and misused. And so I do know that I'm starting to see an increase of elderly women who are functional, who want to be in an environment of people of the same, and not feel unsafe in situations where you're interfacing with 20-year-olds and stuff like that, or people who have more extended needs as opposed to just depression, suffering through loss. And so I do know that that's been something that's been really a barrier when it comes down to what's available for some of the clients that I've worked with. And at this point, my hands are tied because I have no suggestions beyond just going to a hospital. And it's really scary because increasingly I'm starting to see, elderly Black women who have kind of bore things on their shoulders, or elderly women who have bore things on their shoulders, who are like tired now, who have these moments.
And Mr. Williams, we should talk because day programming is available for those folks.
And it's funny that you say that. It's funny that you say that because that's been my only suggestion for day programming. And I felt like that would be the best option. Yeah, but I'm as I get older and as I age, as I'm pushing 50, I'm always thinking, what are the options for me? Like, everything's so young based, and what will be.
And they are. And at MBI, we do provide mental health. We have a large mental health day program, and many of the folks that attend those programs are seniors with serious mental illness. And what we found is that you were asking about stats earlier. There is a 71% reduction in repeated hospitalization for those who are participating with serious mental illness in day programming. So that is a really huge resource. I know we're one of the largest provider of that in the city, but there are also other providers depending on where the geographic location of the person. But I would highly recommend that.
Yeah, and just to put a little marker out there, Umbrella does have a day program as well. And so I do know that it's been accessed. I was a bit hesitant initially, only due to who's present. And I'm noticing that we're getting a lot of elderly show up. So that's a wonderful, positive thing. And I guess I was thinking in terms of hospitalizations, or, a client of mine referred to it as I need a break. I need to step away from everything. But I don't want to go to some of these programs where I don't feel I'll be the old person in the room. And, and I'd rather be around people of likeness. So that's a good point. Day program. Thank you for that.
I would just add to that, the Clubhouse and peer-led programs, the peer-run centers, and Clubhouse is a peer-led rehabilitation program as well. That is, I think, also an important addition back to our continuum of care.
Absolutely.
Well, this is all very helpful because, again, we have elderly patients, or I think people don't like elderly sometimes, senior patients who seasoned, I like to say, who come come into the emergency department and they need resources. They're experiencing loneliness. That's something we've seen a lot during the pandemic, loneliness and isolation. And I might admit them to inpatient, where it's not the ideal location for them, but they are struggling, especially with not having support, with having friends and family members who have passed away. So it's definitely, I do agree with Mr. Williams that it's not only the kids who need help. Like we need help the continuum, the whole lifespan. So yes, and I can say that we need some more Jerry inpatient services. And I agree with the day programs. I've just learned, we've been taking notes here. So I just learned that you all had day programs. So when you get some referrals, don't act like you didn't tell me. I'm gonna be like, me, I know Miss Marilla's Black, and she said my patient could come. And do you know Mr. Williams? Well, he said that I could refer to Umbrella's day program.
Absolutely.
So on that note,
we're in two locations. We're in two locations.
Two locations, yes. Yeah. So please, don't act like you don't know Dr. Harrison when I'm calling. So thank you again to all our panelists. This has been a wonderful resource. I hope to see everyone in July is tomorrow. So I hope to see all of you at our health fair. I've gotten a lot of comments that people are tired of doing virtual. When are we going to be live? So we're going to be live. We are going to be live on Georgia Ave, really, July 23rd. So come out and see us. We'll love to support you and embrace you, do some great activities just to promote mental health and partnerships in the community. Remember, you can follow Black Psychiatry on Instagram and Twitter. We are doing stuff for the kids. That's going to be back in August. Also, just thank you to our partner again in DBH. Howard is happy to work with you from day, from 8 to 5. We work with you in our daytime jobs. Also, the same thing with Umbrella and MBI. So thank you to all of you for actually answering the phone when I'm calling from the emergency room or someone from my team. So thank you for supporting and treating the people with the needs in DC. We are very happy to have this connection. So again, of course, Black Psychiatry, we're here. I'm a doc named Danny or Dr. Harrison. We didn't get to all the questions, I'm sorry. But if you drop them in the comments, I will make sure the panelists get them later and hopefully they'll come back. Yes?
Yes. Thank you for having us.
Well, thank you so much.
Thank you for having me. This was great.
Thank you. And the replay will be up in about an hour or so. So thank you to everyone. Thank you for everyone for your wonderful comments. This makes me feel like I will keep doing it, and maybe I'm going to stick around. So thank you so much, and good night, everyone. Thank you for watching, and thank you for your support, and thank you for supporting the people of DC in our communities. Bye-bye.
Have a safe holiday, everybody. Take care.
Thank you.
Have a great 4th. Thank you. Bye-bye.